Plus is obtained from acids. There are two types of acids in the body, volatile acids and non-volatile acids. The source for volatile acid is carbon dioxide, which is eliminated by the lungs. The source of non-volatile acid is the dietary intake of protein that you take. Every day you take a lot of proteins, all right, in the form of vegetarian protein or a non-vegetarian protein. So this gets converted into acid, and this acid is eliminated by the kidneys. How does the kidney handle acid? By two basic mechanisms. First is proximal convoluted tubule reabsorption of bicarbonate. Second is tubular secretion or excretion of H plus that occurs in the distal tubule or the collecting duct. The distal tubule or the collecting duct, it is because of the sodium, the H plus potassium ion exchanger. Whereas in proximal convoluted tubule, it is sodium hydrogen ion exchanger, NHE. The anion exchanger that is present in collecting duct, it is present in the type A intercalated cells, and this is responsible for excretion of H plus. Why am I stressing on this type A intercalated cells of the tubule? Is that in some patients this tubular cells will be abnormally abnormally formed, either because of genetical or morphological abnormalities. This results in what is known as renal tubular acidosis. Our next topic of discussion after this break will be renal tubular acidosis, wherein I will be discussing the classic distal type of acidosis, type 1, the proximal renal type of acidosis, type 2, and type 4, that is hyperkalemic acidosis. So renal tubular acidosis is occurring because of problem in the H plus ion secretions in the collecting duct. So to summarize the acid-base disorders are you should diagnose in 3 steps. The first step is pH, the second step is bicarbonate, the third step is compensation. First step, pH, once you diagnose whether it is acidosis or alkalosis based on bicarbonate, you can tell if bicarbonate is in line with pH, you are calling it as metabolic component. If carbon dioxide is in line with pH, it is called as a respiratory component, respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. There are two types of basic acid-base disorders, that is simple acid-base disorders and mixed acid-base disorders. In case of simple acid-base disorders, the expected change is equal to actual change. In case of mixed acid-base disorders, the expected change is not equal to the actual change. How to differentiate expected change and actual change, I have already explained you with various examples. In the last, I told you that this person was suffering from diabetic ketoacidosis, this person metabolic ketoacidosis was there, metabolic acidosis was there, metabolic alkalosis was there, and also respiratory alkalosis was there. So this is a triple acid-base disorder. Yes, in some people, normal pH and abnormal PCO2 or bicarbonate, it's a mixed acid-base disorder. In some people, if normal pH, normal carbon dioxide, normal bicarbonate also, then you check the anion gap. If anion gap is normal, it's a normal disorder. If anion gap is increased, it might be a metabolic acidosis unless proved otherwise. So this is all about, in a nutshell, the various acid-base disorders. Hope you have followed the lesson. In the next class, we will be discussing in detail the metabolic acidosis and anion gap calculation, and I'll also summarize with various clinical scenarios. Thank you very much.